Dear colleagues, first of all, I want to thank the organizing committee and especially Associate Professor Karamasis for the very kind invitation to be part of this really educational and innovative meeting. And in the next few minutes, I will present you a case which we handled in the cath lab of Inselspital Bern with Professor Lorenz Reber. And this was a 62 years male patient. He presented to us complaining about recurrent exertional chest pain, especially triggered by after cold exposure during skiing. He was highly active physically, and his past medical history was completely unremarkable. And regarding the cardiovascular risk factors, he was hypertensive under single antihypertensive therapy and dyslipidemic with an LDL cholesterol of 3.55 millimoles per liter. As you see, the 12-lead ECG was unremarkable, and due to the high pre-test clinical likelihood for the presence of coronary artery disease, we decided to perform directly invasive coronary angiography, which revealed a normal left coronary system, and as you see here, maximum angiographically moderate lesion in the mid part of the RCA, which was the case, and to sum up, we have a symptomatic patient with an angiographically at maximum moderate lesion in the mid part. So what could be our next step? Here are our thoughts. First of all, conservative management. Secondly, we have a symptomatic patient, highly active patient, and intracoronary physiology, including assessment of the microvascular function, could be an option. Intracoronary imaging, or regarding the fact that the patient had symptoms after cold exposure, we also thought about a possible provocation test with acetylcholine for epicardial spasm. And I'm ready to hear your thoughts.
Yes, thank you. I think it's a normal angiography. I'm not so sure about the meaning of the symptoms. Okay, there is something in the RCA artery, and can I see in the left arterial descended? Probably I show some like diffusion problem, but I think that I will go like conservative management with some other like ranolazine or like some statin therapy and nothing else.
So how much is this lesion according to? So if you needed to estimate the severity of this lesion is, so if there is a lesion is what, 30%?
I think it's definitely non-significant. So yeah, someone could investigate, but even if you find, some tikva, then why do you need to treat that?
Okay, why the septal? Why this branch, side branch? Is receiving less flow.
I think you mean the branch in the lesion that
Correct, and you can see at the beginning that there is a minimum of staining inside.
But also you can spot that in the second and in the fourth acute marginal branch.
Okay.
So maybe it's,
It doesn't matter.
It's okay. Magic picture.
I think somebody has to take into account that, okay, we should agree with that by QCA is not more than 30%.
Yes, I agree.
The only thing is that we have some ectatic vessel, especially in the proximal and the distal part. I don't know if this is with nitrates or not.
With nitrates.
This is with nitrates. So this is important to have this in mind. So maybe this explains also a bit slow flow in the marginal plaques, but due to the ectatic flow. I think. Okay, there's any other suggestion? Let's go to the questions.
What about, no, can you go back one more second? Can you go back? What about the contrast density is equal between the first segment, the distal and the middle segment, or you have a little bit less evidence of contrast, a little bit of more gray appearance?
2 to 3 flow, but yeah, with of course this incorporates blasting as well. So the blasting, I have to say, I have to admit, it's maybe a little bit redundant.
Okay.
Like, let's say 2.
Please go to the microphone.
Fantastic case. Okay, so you have a patient that is clearly symptomatic. You have an angiogram that you have a right coronary artery, which is 30%. We make comments 20%. Somebody said it's normal, and then ambiguity again. So we need more information. So from my point of view, I would never leave this patient to let the patient to leave the lab without proceeding physiology, acetylcholine test, and then perhaps if everything is negative, then I would proceed to imaging.
So exactly this was our thoughts. The coronary angiogram was not convincing. As you already mentioned, there is a non-significant plaque in the mid-RCA, but we had to deal with a highly symptomatic patient, and we decided to perform an OCT. And here you see the first run. And the longitudinal.
Sorry to interrupt. We'll see it on the screen, and Professor Guagliumi is going to analyze it.
But he said first physiology, second acetylcholine, and then eventually imaging. So
we decided against intracoronary physiology because we already had the symptom, and the symptom was quite convincing for us. And acetylcholine test could be also a very rational option, but we decided to go directly for intracoronary imaging.
Okay, that was the case. Question?
I don't know. We all agree that to have symptoms, we must have...
Microphone.
Yes, of course. Excuse me. We all agree that to have symptoms, we have to have a flow-limiting lesion. We'll agree to that? First of all, maybe it's the physiology part, because can solve our hands. If we have a positive physiology, I don't say my personal opinion if it's mild or moderate disease, that doesn't matter right now. But if we have the physiology positive or a acetylcholine test, we have our diagnosis, and we correlate it with the symptoms of the patient. Then, yes, it's a thought to proceed with imaging to see high valvular plaque characteristics. But first, I would start with physiology, because I think physiology correlates better with symptoms, and then with stability of the plaque.
Okay.
To be honest, I mean, it's a case that we, more or less find it every day in the cath lab. The first, I think, is to check if there is any tight stenosis or any intermediate stenosis. If there is no intermediate stenosis, there is no reason to do any physiology, any FFR, no FFR. In this case, I think that the second probably approach is to check if there is any vulnerable plaque there, because if you exclude, that there is epicardial, any epicardial, let's say, stenosis, any epicardial problem. Afterwards, you go for acetylcholine test. This is the last, I think, option. First option is FFR when you have an intermediate stenosis. Here, there is no intermediate stenosis. So you go straight forward for imaging, and the best is OCT. No IVUS here, because you are not going to have the information you expect. I think there is a kind of plaque rupture there, somewhere in the OCT.
We don't know. We are not still at the point to read the OCT. Okay. We were following the flow.
Okay, so it's just a small comment, maybe question to the audience as well. Can we have a show of hands? How many, in the cath labs that they have acetylcholine in availability in their cath labs? So we have. Are you from the same lab? No. So we have one cath lab in
Italy and UK.
It's Italy, UK, and one in Greece. So so if you don't have,
throughout
if you don't
the
have it,
hypothesis to use acetylcholine. So now we are still to physiology, intermediate lesion. How much is intermediate this lesion? I selected the lumen area distally. The lumen area is 11 millimeters square. And then you have here automatic identification of the MLA in the longitudinal view with this yellow line, and is 4.20. How much is this lesion in terms of a plaque burden? Is 4.20 compared to 11.02. Means that is less intermediate compared to what we are seeing from the angio, that we are moving inside. Now, you can see that a larger circumference of the vessel is losing the light penetration. Here you have dark imaging. Dark imaging going around means that you have a plaque, and the plaque is becoming very high, reflective toward the lumen. So here, there is something that we might call thin fibrous cap atheroma. To say that, we needed to click on the plaque and then going to make the measurements. And we need multiple measurements done at this level. There are no macrophages except this one. Here you have the thinnest part at this point. If you are going here and taking, you can take the measurements at this point from here. It's not easy on this table, guys. It's very, very challenging. I would say that it's lesser than 90 microns. We are more or less at the limit, and we needed to repeat multiple times at this level. Below, you have something that could be, you can see the voids. This is no calcium. This is something that could be lipid core, but we are still not allowed to say that we can detect clearly the lipid core. So, huge plaque burden compared to the lumen, and clearly atherosclerotic in origin in these younger patients with possibly a thin fibrous cap atheroma. And when we are moving quickly proximally, you can see that the proximal part of this vessel is becoming larger and larger. Here, you can see at this point, still with some pathology. I'm clicking, I'm making it smaller, just to give you the essence to everybody. And here the lumen is becoming 12 something. And you can see from the lumen profile that this lesion is not very focal, but is quite long, involving the mid segment of the LAD. So, what to do?
So the next step is that I totally agree with your assessment, and we detected a lipid-rich plaque with some high-risk features like the thin cap, like very high lipidic content, more than 180 degrees arc of lipid, and we interpret these bright spots as macrophages which were accumulated. It could be controversial, but this was our interpretation. And we had to deal now with a symptomatic patient with a vulnerable plaque, a highly lipidic plaque, and the symptoms were from us interpreted as a vasoactive component on top of this high lipidic vulnerable plaque, and we decided to go for stenting, for preventive stenting, which was performed without any problems, direct stenting with a good result angiographically, and also with the post-procedural OCT assessment, we evaluated the expansion of the stent, which was good, without malapposition and without any significant edge dissection.
Comments? So we are still there with a vulnerable plaque. We can go ahead and stent all of this supposed to be vulnerable plaque. Here the plaque burden is significant. You have probably thin fibrous cap atheroma. The thickness of the cap is bordering. So what to do?
But this is an old question. It has been studied time and again with stents, with balloons, and we didn't have any evidence ever even from the air of Bernie Meyer, from Colombo. We were involved in these studies, but of course, Greg Stone studies, the prospect study. We don't have any evidence whatsoever to place a stent in let's say vulnerable plaque. As I said, we have let's say we find a TICFA.
Prevent, Simone was mentioning before, and it was say prevent, yes, in a small sample, and these patients were mainly stable, not presented with unstable symptoms. So there is some evidence. How long is it taking in a patient presenting with thin fibrous cap atheroma, the aggressive lipid treatment to have converted is individual dependent and segment dependent. There is a publication on urine intervention showing that the plaque may respond differently. You have a multiple thin fibrous cap atheroma. If you are aggressively treating with antilipemic drugs, after a few months, you might have a totally different fibrous cap becoming thicker, but you have also other thin fibrous cap atheroma. They are going in the opposite direction. How we can identify and select. The point is, how we already there to say that we have all the characteristic profiles for defining one vulnerable plaque, or we are still quite far away?
Can I ask something? I have some concern about this case. First of all, because there is a malapposition in the proximal segment, and I'm not sure if this is clinically relevant, but if you, go for the run, for the running, you can see it in the 3D image too, that in the proximal portion, there is, go, it's, yes. Now,
if here you have the struts that they are fully against the wall, and you have all the struts around the circumference, so that we are moving to the entrance, and then we are not cutting perpendicular the section, and here you started to see that
you see that
some when we are losing this opposite side, so probably is really the first rim, and the automatic system is telling you that this distance is much less than the minimum critical threshold that is 400. Otherwise, you will see on this bar becoming red spots. So means is limited, is exactly at the first frames at the entrance, and is not reaching the minimum value that normally we need for correcting, because of the small risk out with the balloon and dissecting compared to gain.
I can understand your concern. The second, I would like to comment, and I need your opinion. Why didn't you go for a DEB, drug-eluting balloon, or fully bioabsorbable stent?
That's a very good question. It was the preference of the operating physician to perform drug-eluting stenting. The plaque was soft. It could be also an option, drug-eluting balloon, but it was the preference of the physician.
If we have very limited evidence referring to prevent in treating these vulnerable plaques with the stent, we have much less in using drug-coated balloon. So it's something that is far away to be proven and shown. So if you needed to do something, you needed to do something with the minimum evidence that we have.
This whole session, as I said before, it's at the limits of evidence-based. So the cases that we'll see, they're not cases of necessary everyday clinical practice. Some of them are a bit experimental. This case was in a randomized trial, Interclima. But I think we should go to the next talk and listen more about vulnerable plaque from Leonidas. Thank you, Stratos.
Thank you very much.